So, would like to invite Professor Nitin Kapoor from CMC Vellore to talk on a very important topic. I just came from an obesity symposium just right now, and I know I'm quite aware that Professor Nitin Kapoor is also very actively involved with regards to obesity and obesity guidelines as well. So this obesity and bone, with regards to, we are all also aware that osteoporosis may be one of the, obesity may be one of the protective factors for osteoporosis. So that obesity paradox also. So choosing also the appropriate agents with regards to osteoporosis management. Over to you, Nitin.
Thank you so much, Professor Sanyal, for that introduction to the topic. Yes, indeed, obesity is a big problem, and so is osteoporosis. A lot of links in between. As Professor Sanyal mentioned, there's a paradox here. We'll talk about it. But what I thought in the next 20 minutes I'll do is I'll take you through 5 brief domains covering this topic. We'll talk a bit about the problem statement. We're talking of 2 common disorders. So definitely when you have 2 common disorders, there's bound to be coexistence. But is there an association is what we really need to be worried about. We'll talk about a little bit as to what really is the linkage between bone and adipose tissue. For all of us as clinicians, how this is relevant, how it impacts our clinical practice, but also looking at not just the bone, and especially now with newer medications for obesity, highly effective anti-obesity medications, what impact does that have on our muscle mass and musculoskeletal health? But last, before I finish, I'll also talk about what the different clinical guidelines across the globe talk to us about this aspect. So these are the 5 brief domains I'll talk about. Talking about the problem statement of obesity and bone, I think all of us are aware what we say is the coming of the gray dawn, which means that definitely our life expectancy is increasing. It has been increasing, remarkably over the years, but how it really changes practice for us as clinicians is we are going to see more and more elderly people in our practice. So if we are going to see more elderly people, then definitely we will have to deal with more problems in the elderly in clinical practice, and definitely obesity and osteoporosis do come up as important disorders that we see in elderly. Talking about obesity, yes, the prevalence is big. When we look at data from the National Family Health Survey, about 35 to 40% of the Indian population is either overweight or obese. But specifically looking at data from West Bengal, from this survey, we find there has been a remarkable increase in the prevalence. This is NFHS 4. But what I'd really like to highlight is the prevalence is remarkably increased in men. Conventionally, we've been talking about obesity as a problem of women, but yes, it has increased. You see an increment in men is close to 90%. So definitely this is a big problem. This was NFHS 4. We got NFHS 5 data 5 years later. Whatever was in late 30s has become early 40s, and this is the same story across different South Asian countries. When we looked at data from Vellore, this is from the Vellore birth cohort again, a remarkable jump in the prevalence of obesity between the age of 40 to 50 in this 10-year follow-up. And looking at rural elderly women. Now this study we did in postmenopausal ambulatory women, most of them as working as farmers, mean age is 61. And you see the huge prevalence of obesity that we found in this particular study. Long story short, yes, obesity is increasing. We will have more and more patients with obesity, no matter what specialty we practice, walking into our clinic asking for weight loss. What about osteoporosis? I think this was already mentioned. Different studies across India. A long story short, prevalence of osteoporosis in postmenopausal women ranges from 30 to 70. On an average, most studies would say 1 in 2 postmenopausal women have osteoporosis, about 50%. Men, 1 in 5, about 20% of men have osteoporosis. The mean age in this study was 60 years. So 2 common disorders looking at prevalence, which is very, very high. But why are we so worried? Why are we talking specifically about these 2 disorders? Well, for osteoporosis, we are worried because we know the hip fracture, if it happens, the mortality is huge. If 3 women have a hip fracture today, a fragility fracture because of osteoporosis, one of them would not survive more than a year, about 30% mortality. But when we talk of obesity overlinked with this, then not only the fracture happens early, and you can imagine a patient with severe obesity, how the fracture healing would be, leave aside the mortality and the morbidity which is associated with it. So definitely two common problems bound to be associated, seen together, but also there is a link. And that takes me to the second aspect of the talk. What is the link between bone and adipose tissue? Now, actually, they come up from the same mesenchymal stem cells. So whether it is the bone osteocyte or the adipocyte, both of them actually come from the same cell. I'm not going to take you through the boring physiology, the transcription factors, but for all of us as clinicians, when you talk of skeletal manifestations of obesity, there are lots of them, and you see a lot of rheumatological disorders mentioned here. A lot of it is relevant to your clinical practice. When we looked at data from our obesity clinic, we run a multidisciplinary obesity clinic at Vellore, and we found that about 40% of people have osteoarthritis, which is definitely a big problem. But I thought two important points I'd like to highlight when we talk of bone and obesity. One of them is corticosteroid use, which is again something which is very common in all our specialties of practice. In our clinic, we found that 1 in 20 people who walk into the obesity clinic are on steroids, many of them not even aware that they are on steroids. This is a story I often like to tell. This is one of my patients who had florid features of Cushing syndrome, and her cortisol levels were undetectable. And I kept asking her, are you taking any steroids, any tablet, any injection, any powder? And she would just deny, no, doctor, I have never taken any allopathic medicine. It's only during, bedside rounds. I actually had to admit her to try and understand whether she has some kind of cyclical Cushing's or some rare kind of Cushing's, because she denies intake of steroids and her cortisol levels are low. It's only during bedside rounds that I find she has this packet next to her and she says, doctor, this is a very efficient powder for knee pain. You can give it to your patients also, and when we analyze, it's dexamethasone. So that's a sad state of affairs of steroid use in our country. There's another story of two young boys who presented to us with florid Cushing's. They had prediabetes, they had osteoporosis, but again, the cortisol levels are so low, and we know that this could be exogenous, but how come two brothers with Cushing's? That was, quite perplexing, and later on, during detailed history, we realized that somebody had given a powder to the mother to feed them so that they increase weight. She was diligently mixing this powder, a health drink, giving to her children steroids morning and evening, mixing in milk, and that's how these children had Cushing syndrome. So I think there's lots of association between, fat and bone. One of them is steroids. The second association we did attribute in the previous talk that I gave on, talking about diabetes, which is also a common link. People with obesity have a higher chance of developing diabetes, and again, diabetes in bone. Diabetes is one of the biggest risk factors for osteoporosis, as endorsed by the ISBMR guidelines. The study we've already shown, talking about how in people with diabetes, you can get a falsely high BMD, but again, their bone strength, their bone quality is poor, and they have a higher risk of developing fractures. Well, there are several mechanisms that are described how people with diabetes develop a poor bone quality, and also all the other skeletal manifestations that can happen with diabetes. So two links only I would highlight in paucity of time. One is the link associated with steroids. The other is the link associated with diabetes. So let's move on to the third aspect, and that's what Professor Sanyal mentioned. Classical medical teaching tells us that as we have an incremental BMI, our bone density should go up. That's what we are taught in medical school, that as we have a higher BMI, the BMD would go up. But what happens at the far end of the spectrum? When people have severe obesity, they develop OSA, fatty liver, they have increased fall risk. We keep telling these patients to, eat less. They are deficient in micronutrients. They're often immobile, not moving out in the sunlight. So this was a research question we started initially. This is a paper that was published long ago looking at BMD. So definitely if from normal BMI, you go up to an increased BMI, the BMD increases, but once it becomes in the range of severe obesity, there's a drop in BMI, and it's more dropped in the femoral neck. It's shown in Western literature as well. And not only the BMD, but even the bone microarchitecture. In this paper, we looked at the trabecular bone score also in people as they increase BMI. So it does increase non-obese to obese group, but later on does become worse when they become morbidly obese. So for all of us in clinical practice, if we have patients with severe obesity, we don't think that their BMD would be very good. God forbid if they develop a fracture, the healing of fracture in people with morbid obesity, given all that weight bearing that happens, becomes really, really difficult. So with this, moving on to the fourth aspect of my talk, which is becoming increasingly relevant as of today, because we have these newer anti-obesity medications that cause significant weight loss. But what's the impact of these medicines on muscle mass, right? So all of us are here, we're talking about bone, we're talking about fat, joint comes together, and it's all together. And one of the main attributes of aging, apart from having more obesity, apart from having more osteoporosis, is developing low muscle mass and increasing fat. So as we grow older, our muscle mass comes down, our body fat goes up. And therefore, definitely people who have sarcopenic obesity, which means low muscle mass and increased adipose tissue, definitely have higher chance of developing knee arthritis as well as osteoporosis. So how is this relevant? This is a slide that I showed, and I'll highlight again. We keep talking so much about obesity as an important problem. Yes, obesity is important for mortality. Sarcopenia is important, but combined together, the mortality in this prospective study tells us it's much, much higher. And this is, again, something that I showed, that sarcopenia is indeed prevalent in our population in a large number. So what happens when we have these newer, highly effective anti-obesity medicines? So this is a short summary of all the medicines that we have. At this point, we have semaglutide and tirzepatide available in India for use in people with severe obesity. The others are in different phases of clinical trial, mainly phase 2 and phase 3, retatrutide being the most effective. So when these patients lose a lot of weight, you see 15, 20, 25 kgs, what happens to muscle loss? So if you look at data from the STEP 1 trial, which was the first study which showed first time an anti-obesity medication could lose weight close to about 15 kgs. So how much of muscle loss was there? So if you look at the body composition data, which is available only for a subset, we find that these patients who've lost about 15 kgs, about 8.4 kgs is fat loss, but about 5 kgs is muscle. In short, what you need to remember, if your patient is losing about 10 kgs of weight with these medicines, 70% of this is fat, but 30% of this is muscle, which is important given what I've shown in terms of sarcopenic obesity, the mortality, the morbidity that it carries, it is important. Similarly, looking at tirzepatide, this is data from the SURMOUNT-1 trial. Again, these patients had phenomenal weight loss, about ranging to about 20 kgs. Again, the quantum of weight loss, 15 kgs lost in terms of fat, 5 kgs lost in terms of lean mass. So again, something easy to remember. Every 10 kgs your patient loses with the help of these medicines, about 30% is muscle loss, 70% is fat loss. There are several other studies, one with oral semaglutide and Ozempic subcutaneous semaglutide, similar numbers. 8.5 is the fat loss, about 2 kilograms is the muscle loss. So what can we do to prevent this? Yes, diet, definitely exercise as well. So combination of both resistance training and aerobic exercise is helpful. Improving the protein intake, which is very relevant again to our population, is helpful, and making sure that they get adequate amount of calcium and vitamin D as well. So there are several guidelines which have come up as to how the nutritional counseling for these patients who are being prescribed these medicines, which are really selling right now as hotcakes. We see that these patients should get adequate amount of fluid intake, good amount of protein, fiber, and also very important to look at the micronutrients. Like in patients with bariatric surgery, we tell them that they have to have a multivitamin tablet lifelong. Similarly here, the micronutrients become really, really important. We recently reviewed literature looking at how in patients who are on these medicines, the nutrition impact, but also the impact of gut microbiota. So far, we keep talking about gut microbiota as something which is important, but a lot of preclinical work. But now there is good clinical evidence which is emerging as to how that can be very, very important in improving muscle mass, especially in these patients who are on these medicines, and also some newer medications. The EMBRACE trial was recently published where they looked at the effect of myostatin inhibitors when combined with tirzepatide, and then how much of muscle loss can be prevented with the help of additional of these medicines. So this is emerging literature for myostatin inhibitors and certain SARM group of medicines. So with this, I think I move on to the last aspect of my talk, talking about the clinical practice guidelines for obesity and bone. What do they tell us? Well, most of the obesity guidelines today will talk to us about how it is important to improve the quality of life of these patients. Just don't look at numbers of kilograms that is lost, number of, the fat percentage which is lost. And if you are really looking at quality of life of these patients with morbid obesity, I think what is really important is to make sure their physical impact is less altered. And with severe osteoporosis, fractures, osteoarthritis, this is something that needs to be addressed. The mechanical component of obesity is sometimes often missed. Many of us as physicians are really good in assessing the metabolic aspects, but how much of the mechanical aspect do we assess? And this is something important. What the other guidelines also talk about is to make sure that when you have patients with severe obesity, take care of their micronutrients, especially calcium and vitamin D, and protein intake, especially now when you have these newer medicines. When you look at guidelines in terms of bariatric surgery, again, bone health assessment becomes really important because, again, when these patients lose a lot of weight after surgery, it is important to make sure that their bone health assessment is taken care of. And definitely in people with diabetes, our national guidelines has a separate section on osteoporosis as to how this is important and how the T-scores and the BMD may not be as reliable, and trabecular bone score may be something that is used. When we look at the ISBMR guidelines for osteoporosis management, enough and more has been highlighted as to how diabetes is an important risk factor, and even the international guidelines endorse the usage of TBS in these patients. So I think with this, I will stop. These were the 5 domains that I covered very briefly, talking about 2 common disorders, how they are linked to each other, how it is important to remember that, yes, BMD increases with weight, but once people become severely obese, they have a drop in their bone quality and strength. Also looking at the impact on muscle mass, especially for these newer medicines, and what the guidelines have told us. So with this, I'll stop and be happy to take any questions.
Thank you for an excellent presentation. A couple of short questions. One is with regards to obesity, and especially with background diabetes, one can have cardiovascular risks. So the choice of osteoporotic agents with regards to the different choices which we have, including romosozumab. Second is with regards to use of anti-diabetic agents like SGLT2 inhibitors and pioglitazone, and the impact on what choices would we have?
So I agree, very, very important question. So yes, first taking the second question, when you have diabetes and osteoporosis, the class of drugs that we avoid include pioglitazone. SGLT2 inhibitors, initially there was a scare, more recent meta-analysis tells us they are okay for bone. Talking about the first question, anti-osteoporotic agents in patients with cardiac disease, as Professor Thomas Paul already mentioned in his lecture, if somebody has had a cardiac or a vascular event in the last 1 year, you wouldn't like to give romosozumab for them. If they have structural heart disease, again, zoledronic acid, looking for atrial fibrillation is something which is important. But by and large, I think the benefit is quite good.
Yeah, I have a question. Obesity is being considered as a pro-inflammatory state. And nowadays, it is found that inflammation has a role in age-related osteoporosis also. Your comments?
Exactly, and that is the precise mechanism how people with morbid obesity develop osteoporosis. You know, fat is protective because fat produces estrogen, and therefore it is protective for bone. But it is the severe obesity, which is associated with OSA, with fatty liver, and all these pro-inflammatory conditions which hits the bone. So definitely correct, obesity, inflammation, and that's how the bone gets affected in severe phenotype.
Yes, inflammation, I think, activates osteoclasts more.
Correct.
Any comments, any questions from floor? We are before time, so we can have many questions or comments.
Yes.
in the semaglutide and tirzepatide studies,
Yes, sir.
was there any difference in protein intake in the Indian subgroup versus?
So I think that data is not available. Even to get this data, I mean, step 1 trial and Mount 1 trial were done in a lot of patients, but we have data on body composition only in 70 or 80 patients. But we are right now working on a real-world trial on these drugs. We have body composition analysis at baseline at 1 month, 3 months, and 6 months with dietary data. We should have some answers with that in 6 months' time.
Thank you.
So I have a question. Osteoarthritis and osteoporosis. So how they are related? Linearly correlated or just the opposite?
So I don't think we can correlate it directly because it does depend on a lot of other factors as well. We did, one of our postgraduates did a thesis last year looking at osteoarthritis and bone disease. And we did this novel aspect of looking at knee DEXA as to how that is affected in people with severe osteoarthritis. We didn't find good correlation between osteoarthritis and peripheral DEXA of the spine and the femoral neck, but we found good correlation with knee DEXA because obviously that is the area which is affected. But I think there are so many factors that affect osteoarthritis of the knee, right from weight, the age of the patient, and other local factors that I think it's hard to correlate.
There is a complex thing that osteoarthritis sometimes is said to increase, decrease osteoporosis, and just the opposite. So what is your view on this?
Right, sir. So as I say, there are so many confounding factors in that, may not be able to clearly delineate each of them. So I think it has to be patient-to-patient basis.
Thank you. Thank you.
Actually, that was the previous findings, previous publications, some 15, 20 years back. For the last 10 years, the publication, including one of publication in our institute by mine, the osteoarthritis and osteoporosis can go hand in hand, particularly in obese patients. Obesity is a common risk factor in both. Any other questions or comments? Yes, sir. Come, please.
When you are postgraduate was doing the study, doing a knee DEXA, was it a right move because we expect a little plus upon sclerosis in osteoarthritis? Probably there you're looking at, we should have done the hip DEXA.
We did the hip as well, but looking at knee DEXA especially, if you have to diagnose osteoarthritis, you can diagnose clinically. There are very good scales which are available, but if you want to follow up to say whether there is improvement or not, you need a good imaging. Yes, X-ray, there are scales which are available, but whether DEXA can be used for that, that was the main aim. We followed a standard protocol for knee DEXA, which has been established before, and we've done another study before that. But we were not just looking at the we divided the knee into 4 areas to look at which area correlates better. So it was just a pilot to begin with.
The site of knee DEXA, I think, is the lower end of femur, not exactly at the knee joint. Is it?
No, sir. So lower end of femur and upper end of tibia. That's
Both.
how both were used, and two analysis for each.
Okay. But that doesn't include the knee joint, where osteophytes are getting formed.
It probably does. The lowest part of femur and the highest part of it probably does include, but the penultimate parts don't.
Okay. So there may not be any sclerosis, any increased bone density.
No, there was.
If
we didn't find.
osteophytes are excluded in the scan, though there may not be any increase in the bone density.
Exactly.
Yes.
Yeah, so this is more of a general osteoporosis question, not obesity per se. So of late, past 2 years, I've been observing more and more of young boys, 20s and 30s, they are getting osteoporotic. And this was not, I've been practicing for around 15 years, this was not like that. And I personally feel that is a growing entity called post-COVID osteoporosis. What is your take on that? Inflammation part, or is it the steroid which maybe have been used? But this is I'm observing of late.
So in our practice, if we see young patients with osteoporosis, 2 important things that we do. One is go for a very strong family history, try and screen their parents, their siblings, And many times you'll get the answer there. Everybody may have a low BMD. So that's one genetic cause. We've had few which we say as juvenile idiopathic osteoporosis, a known entity because of an LRP5 mutation, which is again something which is known and established, not very common though. Now, if COVID has actually increased osteoporosis, I don't think we have so much literature right now. The steroid use was not very prolonged to cause so much of increased osteoclastogenesis. I would say that we probably need more data to that. But at this point, if you in your practice see a lot of patients with young osteoporosis, please do screen the family. Many times you will get an answer.
So we did screening about 20% of patients, but on the contrary, even the parents did not have such. But then the literatures on post-COVID inflammatory cytokines causing osteoporosis is growing up. So,
Sure.
Excuse me, sir.
with pain, backaches, these kind of musculoskeletal.
That's what I'm asking. Because they have
We-
different pain, and probably they don't have osteoporosis. They have just musculoskeletal pain of some other cause.
Right. So, but if the DEXA is showing low bone mass,
severe osteoporosis, and with teriparatide, some of them have shown improvement as well. They still follow up, but then.
But again, a very gray area. Whether you need to treat them also is a big question. How long can you give teriparatide?
Yeah,
What will you
yeah.
give them when they become 50 and 60 and develop actually
Yeah.
senile osteoporosis? A very
So
gray
with
area.
this-
We don't have much answers there.
So
But
with
then a
this,
lot of
I think,
literature is mentioning this condition.
with this, I think the session should be concluded because
Sir,
it has
just
run
one
over
question.
time. Thank you. Thank for all the participants. Sorry.
Thank you so much, sir.